behavioral health. I'm one of the crisis systems managers. We're, in Virginia in the continuum of crisis services. I am joined today, and we will go through introductions of the people who actually do all the good work and run these fantastic systems. They're the program and clinical directors with REACH. Just a little brief level set on the history. The reason for, the need for services, for DD services and crisis services under that umbrella of those diagnosed under the DD umbrella of services started about 10 years ago when Virginia entered into a settlement agreement with the Department of Justice. The Department of Justice, upon investigation, determined that individuals who are living in more congregate institutional settings could be served in their communities. It was also identified at that time that those individuals moving into those, smaller community-based settings, less restrictive, more integrated, also had some significant complex care needs. It was also identified that Virginia did not have an adequate crisis response system, which is where we are today with the development and implementation of the REACH program. Virginia remains under that settlement agreement. And as Kendall indicated, we have a presentation today. It consists of PowerPoint, which will be presented by the REACH program and clinical directors, and we'll have a Q&A at the end. The slides also include some contact and coverage information that programs often and teams often find helpful for what service connects to my area, because Virginia breaks down services in lots of different ways. REACH is a statewide program broken into 5 regions, and I'll go ahead and let those directors introduce themselves. I guess we can just go chronologically if you guys want to just introduce yourself and give a little bit of information. I guess Larissa. Is Larissa on?
Hey there. Yeah, couldn't find the mute button. Hey, Denise. Good morning, everyone. My name is Larissa, and I am the program director for the REACH Region 1 adult program. So we serve individuals 18 and older in my program.
Good morning, everyone. My name is Liv O'Neill. I'm the program director for REACH Region 2, which serves the Northern Virginia area.
Hi, I'm Dr. Erica Whiting. I'm the clinical director of REACH Region 3, and we serve all of Southwest Virginia across the lifespan, so children and adults.
Hi, I'm Autumn Richardson. I'm the Region 4 REACH Director, and we serve Central Virginia and surrounding areas, so 7 catchment areas in the middle of the state, and we're also lifespan coverage out of my shop, so birth through the end of life.
Thank you. I'm not sure if our Region 5 person was able to join. Oh, hey there, Sheila.
Good morning, everyone. I'm Sheila Reeves. I'm the Assistant Director for the Region 5 REACH program. It does serve the adults and children. We span the southeastern region from Eastern Shore and the 7 cities through the Middle Peninsula areas.
Thank you. And we can, thank you, Lee. We can go ahead and begin as everybody, how the program will work. Each person has, identified slides they'll be presenting, and we should be able to move through with that.
Erica went off camera right at that
time. I had to go off camera. Working from home, there's a dog issue sometimes, and somebody walked by the house. So we're just going to do this auditory for a minute while I get away from them.
Oh, that's hilarious. Wow.
I apologize. Normally they're pretty good, but somebody decided to go for a walk today. So there we go. So I'll just go ahead and jump right in. As Denise mentioned, with the transition from training centers into the communities, we have a series of individuals who now need supports in the communities. And our goal is to support that individual with a developmental disability to live the most inclusive life possible. That motto that we tend to throw around the state is a life like yours. And so being able to have access to effective mental health services, crisis stabilization, and crisis prevention services to fully support that community integration and reduce the risk of any unnecessary hospitalization. Denise, really, we all went over the regional pieces of our program. We are a regional program divided by 5 different regions. And Denise will actually go into more detail about that in the next, towards the end of this training. Next slide, please. So who do we serve? I think you had a good flavor of that as we introduced ourselves, but we are a program that serves children and adults with a developmental disability and co-occurring behavioral health needs or a challenging behavior. So for referral purposes, developmental disability is an umbrella term, and it includes a wide variety of diagnoses. And unfortunately, there isn't a list that's like, this is a developmental disability, this isn't. But for your purposes, it includes things like intellectual disabilities, autism spectrum disorders, various genetic conditions, and in some cases, a traumatic brain injury could be counted as a developmental disability if it occurred during the developmental period, so prior to the age of 22. And these are things that, you know, if you're not sure, reach out to us. We'll talk about it with you. We'll get a better sense of what's going on, because that can be a fuzzy definition sometimes by the state's definition. Anyone eligible for REACH should have some type of challenging behavior or behavioral health concern, like mental health concern, that places them at risk of crisis or actively in crisis. So that key word being crisis. We want to work with people in crisis, or we want to prevent an impending crisis. So we have folks who have developmental disabilities that are doing well. They don't need REACH, even if they're homeless. As long as they have capacity to make decisions and they're just doing their thing, they may not necessarily need REACH. And that's an important distinction, that crisis piece. Next slide, please. So getting into, you know, what our service is, what our goals are. We are a short-term service. And with that, in order to be short-term, one of our hallmarks is that we take a teams or systems approach to work with clients. So every identified client is embedded within a larger system. And to effectively serve them, we have to support those folks who work with them, who live with them, who are around them, in order to help them meet their goals. Because if we come in every time there's a crisis and we do our thing and pull right back out, we ensure that we get to come back in with that next crisis. And our goal ultimately is to give you the tools needed and expand that scope so other people can support this individual. So we don't always have to come in. Essentially, we're working ourselves out of the job. But we are a heavily team-based a team focus, essentially. So getting into that piece, I'll get into the next slide and talk about just the overview of what we tend to touch on, and Leave and Autumn and Larissa will get into the nuts and bolts of, you know, how do we do this? I'll tell you the what, they'll tell you the how. So in order to effectively support teams and help them meet the client's needs, we really want to focus on education and training. You know, not everybody gets solid education and training on how to support an individual with DD. And so this could include the individual's family members, paid providers, people living in that person's community who may have daily interactions with this person, and then other people in that person's life. And this training and education might focus on best practice interventions for specific diagnoses. So what do I do with someone who has autism, who comes to the library and has a meltdown when they don't have the book they want? Or education about a diagnosis and just better understanding what might come with specific diagnoses. Like, what can a person with a mild intellectual disability do? That's kind of a trick question. It's very individualized. But telling you more about that in the context of this individual, and then give you some tips and strategies that might be effective for preventing or intervening during a crisis. It's that teach a man to fish idea, or teach a person to fish idea, where, you know, we want you to be able to grasp those skills to support that person. The assessment piece, and if you haven't picked up on it yet, this we're going in these columns in order of that REACH acronym. So REACH stands for Regional Assessment, Crisis Services, and Habilitation. So we're on that assessment piece. And that really focuses on developing a comprehensive understanding of the situation, presenting symptoms, any diagnoses they might have, the function or the purpose of their behavior, and in the context of any medical issues or environmental factors that might impact their functioning. This really helps us paint a clear picture of what is going on with this individual and what their needs might be, so we can develop a solid individualized treatment plan. It's just like if you went to the doctor for surgery, they want to have all the labs drawn. They want to know your history. They want to know what's going on in order to figure out what to do next. They're not just going to open you up and start rooting around in your body. At least I hope not. So a little bit about crisis services. REACH staff are available 24/7, 365 days a year for crisis response to de-escalate that situation and avoid unnecessary psychiatric hospitalization. And I think that's the key word. I think sometimes people say, well, you have to prevent psychiatric hospitalization. And the key word is unnecessary. Not everybody who has an escalation needs to go to the hospital. And so our goal is to provide that crisis response, co-assess with a pre-screener or whoever else might be responding to the situation, and give them some input on next steps. Give them an idea of this person actually might be served in the community given their supports on a crisis plan. But we will not only respond in that crisis situation, but also provide crisis services beyond that. So up to 7 days, up to 15 days, depending on the need. And it's all dependent on that assessment and what's going on with the individual. But we will work with the team and the individual to build those skills once the initial crisis has passed. And then that final piece in terms of habilitation, we want to teach skills. When that individual is no longer in crisis, they're able to learn new skills. And that's when we focus on prevention. And I think that's what differentiates us from other crisis programs. Other crisis programs, they come in, it's just like going to the ER. You come in, you deal with the presenting issue, and then you leave. With us, we understand that in order to prevent crisis, we have to work on what brought them here in the first place. What are the skills that they're lacking in, team and individual, and what can we do to build that toolbox so that we can recognize early signs of escalation, intervene early, and know what to do if everything just kind of falls apart. Everybody has a bad day. Everybody is, entitled to that. But hopefully we can build a system enough and build the individual's skills enough that they can see those early signs and get to a point where they're not in crisis, where they don't have to go to the hospital, where they don't have to be pre-screened or endure some other more restrictive level of care. Ultimately, it goes back to a life like yours or a life like ours. We want to increase everyone's sense of autonomy and self-efficacy. And like I said before, kind of work ourselves out of the job. Next slide, please. So just to recap, REACH serves individuals across the lifespan, adults and children with DD and co-occurring mental health concerns or challenging behavior, who are either experiencing a crisis event or at risk of experiencing a crisis. We work with the individual and their support system to assist with stabilizing them in a less restrictive setting. Next slide. And then, because our goal is to prevent unnecessary hospitalization, we work with a number of providers. I mentioned that team-focused approach. So this is just an example of what providers we might work with and how we might work with them. So going back to the original, providers and family, people in that immediate circle, we're not meant to replace any specific staff or family member or service. Again, we're short term, so we're there to support them. We want to get a better sense of, okay, what skills do they have in place? What do we need to build up? And how can they continue to do the work without us being there eventually? We work with ES, so emergency services. And we co-assess when someone shows up on emergency services radar. Let's say they're in crisis and someone says, oh my goodness, this person needs to go to the hospital. ES steps in, we step in, we do a co-assessment. That being said, it needs to be clear that we don't pre-screen. We aren't certified pre-screeners or anything like that, but we're basically consulting. We offer insight into that presenting behavior. We recommend services and supports. And then should that individual actually need to be hospitalized, we will assist them through that TDO process, should that be necessary. So oftentimes when someone's TDO'd, if it's their first time, it's their 25th time, they might not be feeling so good about that. And so we have the skills and the tools to support that person to go through that process. Give them a heads up about what's going to happen, what it might look like to be transported from an ER to a hospital, and do that. So maybe we reduce the risk of trauma when they do get hospitalized. We give them a sense of what to expect, so it's not so foreign to them. And then if they are in the psychiatric hospital, we work with folks at the hospital, social workers, treatment teams, to assist with step down or transition from the hospital to a less restrictive setting. So ultimately, we want to help that individual return to the community with effective supports in place and ultimately decrease that risk of rehospitalization. So to talk more about crisis services, I'm going to turn it over to Leave.
Hi, good morning. So to start describing the type of services that we provide, the first type of service we provide is the Reach Mobile Crisis Response. Each of our regions operate a 24/7 crisis line. This does serve as our single point of entry into the program. Individuals, stakeholders, community partners, family members can call our crisis line. Each of them are manned by our Reach coordinator, where we will triage the call and we can provide de-escalation over the phone. We can answer brief information only calls. And the last type of support that we can provide over our crisis line is a face-to-face crisis response, which is typically done where the individual is. We will meet that individual where they are during that crisis response. It can be their natural setting. It can be a hospital setting. It could be an emergency service location. It could be a local grocery store, wherever the individual may be at that time. Again, we are a lifespan service, so we are cross-trained to provide supports to both adults and children. If an individual is referred and accepts our services, we will begin the crisis stabilization planning. We can provide crisis supports to the individual, the family, providers, and any other system members that are involved. All individuals will also receive the development of a crisis education and prevention plan. These are pretty robust plans that take anywhere from 15 to 45 days for development. And we do take information from all system members. What works in one environment may work in another, and we help to connect those dots and make sure interventions that work are shared amongst all system members. Again, the crisis education prevention plan is a person-centered, strength-based plan. This is our mobile crisis response. This is a pretty neat flow chart of how our services can begin. Again, if a phone call comes through our crisis line, we can provide immediate crisis response and assessment, and then a development of a crisis stabilization plan. From there, our trained staff will go in and work with the individual, observe their interactions with the environment, and put that into the CEPP. After the crisis event ends, the individual will continue to receive REACH prevention services, which is often follow up with the individual, their family members, to see if those interventions that were developed during mobile crisis supports are effective. If not, we will continue to observe and make revisions as needed. Next slide, please. Again, we're also able to provide support for individuals who may not be able to maintain stability in the community setting by facilitating admission to one of our crisis therapeutic homes. There are 2 youth crisis therapeutic homes. So these are homes that can serve individuals 17 and younger. One is located in Culpeper, Virginia, which is operated by my program, Region 2, and the other one is located in, I believe, Chester, operated by Region 4 and Autumn's team. There are adult crisis homes located in all 5 regions. And after admission and discharge from one of the crisis therapeutic homes, there will continue to be that post-crisis follow-up by our REACH coordinators. Next slide, please. The first type of admission to one of the crisis therapeutic homes is the crisis stabilization admission. These are individuals, adult and children, who contact our crisis line and require immediate crisis response. This is typically an admission that is used as hospital diversion. Again, individuals with IDD may be better served in a community-based setting and do not require inpatient support. At that point, again, our staff will respond in person, provide an assessment, and triage to admit to our crisis therapeutic home. Next slide, please. Some examples of when an individual would be eligible for a CTH would be if they are experiencing behavioral or mental health challenges that do put their current placement at risk. These are also situations where their primary caregivers are no longer able to support them safely in that setting. And also this could happen when there's interpersonal conflict within that setting where it is of benefit for the individuals to be separated. Next slide, please. Again, this is a flow chart of what a admission to the therapeutic home is. I would like to highlight that these are short-term stays. These crisis homes are not intended to be long-term placements for individuals with IDD. Typically, admissions are less than 30 days. Each region has different average lengths of stay. I know for my region, it can be anywhere from 15 to 18 days for a crisis admission.
Okay, and I will talk to you a little bit more about the homes and the admission processes. As we've mentioned, there are the adult crisis therapeutic homes and youth crisis therapeutic homes, and we've talked a little about length of stay. We do typically look at the assessment lasting about 15 days, and then a second assessment can be completed for a longer length of stay. There are times when someone may be approved for a briefer, more like a 7-day stay, and we do see that more often with our youth. That shorter length of stay is more typically clinically indicated, just because youth do better being stabilized in their home environment and with their family or caregivers involved in their care, and then returning back to their routine. But as we know, many of our adults also benefit most from that shorter term model. And so the length of stay maximum of 30 days, because beyond that, we're starting to look at more as a long-term service, and that's not the intention. To be admitted to the homes, it is a process. You know, we can do this all hours of the day and night, but there are a lot of pieces that have to fall into place for that to happen. And so I'm just going to quickly go through those. For children, there of course has to be consent by the parent or guardian. Many of our adults that are in the REACH population also may have a substitute decision maker that needs to be involved. So collaboration with the substitute decision makers is necessary. Also for children, we're going to be coordinating with their school if it's during the school year, ideally. So we're going to be getting parental involvement and notification provided to the school with their blessing, so that we can make sure that we're not doing anything that would damage their specialized school services. If there's the ability for them to participate remotely in learning, we may be able to coordinate for that to occur depending on the acuity of the child's needs and things like that. For all of our admissions, we do require that individuals come with any medications that they take. We do not, we can provide some of the over-the-counter medications as long as they're ordered by a physician, but we do not have a pharmacy on site. These are home-based services, so our services look like they're taking place in a home, and so it's not the same as going to a hospital where they would have the medication supply on hand or readily accessible. So we do ask that they come with at least 2 weeks supply of medication. They do need to come with those medications in labeled prescription bottles or over-the-counter bottles. Sometimes individuals will have the bubble packages, and that's fine as long as those are, pharmacy issued and not expired or anything. We require orders to administer those medications as well. And so sometimes that's going to be their prescriber in the community, and sometimes that may be an emergency department or patient first physician that is ordering those medications. We do have standardized forms for our admission processes. They're the REACH medical orders and the REACH medical screening form. And those are the preference for the any admissions to come with those forms, just because we know quickly what we're looking at. And if, and our licensing specialists that may come do a pop-up, they know what they're looking at when it's on those forms. However, we also understand that sometimes, if someone's been in the emergency room for the last day or so, that the hospital may already have a health and physical and orders they can produce that exist in their EHR. And, typically we're going to accept that as long as it has the components that we need versus putting more burden on other emergency systems. But we do have these standardized forms that you would be provided. The medical screening form is not a medical clearance form as much as it is, let's make sure this person doesn't have anything that is acutely medical going on that could impact their health and safety if they come into the home. We want to make sure that if they have a UTI, it's not that that's a barrier to admission, but we need a treatment plan in place to address it and to treat it appropriately so that this doesn't, further exacerbate health and safety or behavioral challenges. So we just want people to be well. And if there are treatment needs that need to be addressed, we want to plan for that in place when they come. For out of region referrals, obviously with each region has their own adult home, and then with the 2 shared homes for children across the state, we do have people that travel around Virginia to access the REACH homes. If my home is full, then they may go to Leaves or Erica's, and vice versa. And so we do coordinate between regions. If the home region or the sending region is going to be in collaboration with the appropriate REACH program, to make sure that that goes as smoothly as possible. So both programs would touch that case in terms of the admissions paperwork and facilitating that. A lot of the individuals will come to REACH, to the REACH homes already known to us, but sometimes there'll be people that we're encountering for the very first time in a crisis. And so we're going to start a referral form to go ahead and get them open to the entire REACH system too, so they can get those preventative services upon discharge. And again, that most individuals do accept that. That feels like added value, but to access the crisis services, you do not have to be wanting to be part of the longer term service model though. Releases of information for any key providers. As we've mentioned a few times, we're a systems approach. So we want to collaborate with existing prescriber systems, service coordinators or case managers, schools, et cetera. And then we will, of course, do provider choice. There are other crisis systems in Virginia. We are the ones that are specially trained to work with the IDD population, but that doesn't mean that every person would prefer to work with us over maybe their local CSU or a community-based crisis system. And so we offer choice, of course, in that as well. And then the last piece is working with the system to coordinate transportation. REACH is a big system, but our resources also have limits, just like all of the community-based systems. And so we collaborate around determining what the best way to get the person to us is. Sometimes that may be a hospital, helping to coordinate Medicaid transportation. Sometimes that may be a family or caregiver bringing the person. Sometimes that may be, a meet in the middle if it's a long distance and having reach support, the admission happening along the way and getting them all the rest of the way. So we can be creative, but it is more often that the provider is bringing the individual and participating in the admission process, or the family member is. We have another level of care in the crisis therapeutic homes that's a preventative level of care. Some people can come into the homes that are at risk for crisis, but perhaps are not quite acute enough that they're at risk of hospitalization or incarceration or losing their housing. They're not quite at that moment, but we're seeing that they're off their baseline. There's an increase in their psychiatric symptoms, or their behavioral indicators are ramping up. So we know that things aren't going well. Perhaps they've had a trauma or a recent loss, or it's the anniversary of a loss of someone in their lives. These are great opportunities for people who are known to our system for us to get ahead of it and hopefully help them stabilize more quickly and step down back into their home, or their setting that they reside in. Now, the admission policies are really the same. We're still going to need to have medical orders and, physician screening to make sure that they're, not medically acute prior to coming, or that they have a treatment plan that meets their needs. They still have choice. And so all of those other pieces are still things that we obtain. We just may have a little more lead time, to be honest. If it's a preventative stay, we can start working on that maybe an extra couple days early, so that it's not quite a rush in the middle of the night. Okay, so this slide just kind of elaborates on that. It is important to note that, how we use our crisis education and prevention plans, which Liv had mentioned previously, individuals that come in for a crisis admission, we may or may not have a crisis education and prevention plan yet, but we're going to get it started while they're receiving services. For people who are coming in as a preventative stay, they're already known to REACH most likely, and we already probably have a crisis education and prevention plan that exists. We will use this opportunity to review it, revise it as needed. In the case that someone is coming through that doesn't have that fully done, we're going to still work from goals and objectives that are individualized and that speak to their specific risk factors and target kind of crisis behaviors. We also do step downs from different levels of care. Most often those are step downs from state hospitals, private psychiatric inpatient units, sometimes jail or juvenile detention for youth. And crisis stabilization units will occasionally even refer to us and say, we've worked with him for the last 7 days. We feel like there's a lot more that he could benefit from, but he's just not going to get it at this level of care. This isn't our target population. This is, there's further support that they need. And so sometimes we're not quite a lateral, but a slightly lesser level of care than the CSU, because we don't have the 24-hour medical on site that most of the CSUs have. So we're slightly lesser level of care, and our services look a little different just because of the difference in populations. Okay. This one. So crisis prevention services is another level of care. And we've alluded to the fact that when people are transitioning out of the crisis back into their home environments, that there's a lot of preventative work that our program can continue to do. And so these are supports that we're leveraging in order to try to help reduce the frequency or the intensity of future crisis events. And again, Erica said it really nicely. Our goal is to work ourselves out of a role with this person. And so we're going to be using the crisis education and prevention plan, making sure that that is solid, that that's making sense for this person across different settings. We're coaching their systems, we're coaching them. A lot of the work we're doing is one-on-one, and a lot of it is systems work. We are using evidence-based clinical interventions and strategies to reduce the risk of further decompensation in the future. And so these are, preventative. We have a whole team that does this work, and they have assigned caseloads. These are not individuals that will likely stay open to preventative coordination services, open-ended, but again, are intended to make sure that that plan is working for the person, that they know who to call, which is us typically, should things become more acute in the future and they need more support. And, and ultimately this plan is really the core of that. Our crisis education and prevention plan is like our service plan at REACH. And just a little bit more about that. You can tell we really care about crisis prevention services. You may hear more and more, especially in coming weeks, as we're getting closer to the 988 number rolling out, Marcus Alert, and the Marcus Alert legislation becoming live. So we have a lot of things going on in the crisis system right now, and much of it is based on the national model Crisis Now. And so I will just say that our crisis education and prevention plan that REACH has been using for close to a decade, I guess, at this point, is really unique in Virginia, because we've been doing systems crisis planning work and prevention work for that long. And that is something that's going to be new in Virginia to the mental health system as we start to do services that have more of a prevention component and have the cross-system crisis planning element to it. So I won't reiterate all of the other pieces, but just understand that's what this document is to us. And it's something that has been unique in the REACH system that is very similar to Crisis Now, which is evidence-based. Okay, it's Larissa.
Thanks, Autumn. Okay, so let's talk a little bit about the expanded adult population. We've talked a lot about REACH, who we are, who we serve, and the typical REACH services are everything that we've encompassed and talked about until now. So now we're going to talk a little bit about some changes that were made in April of 2020, wherein the program expanded the eligibility criteria for adults age 18 and over who qualify for REACH services. So just want to stress that these changes that we're going to talk about now only apply to the adult population, so those individuals 18 and over. Of course, we know that REACH, right in the services we've already discussed, serves individuals diagnosed with a developmental disability. The changes that were made in April of 2020, if you want to go ahead to the next slide, we'll look at what those changes mean and the expanded population, what that covers. Person over the age of 18 who is not formally diagnosed with an IDD diagnosis. So a lot of the folks that we work with will see diagnostic information about borderline intellectual functioning. Very common in the people that we serve. We see it very often. They may meet criteria for REACH crisis response and concentrated mobile support. We're going to talk about that a little bit later. And if all of the following criteria are met, we will provide those services to these adults. Like Erica said earlier, please don't hesitate to reach out to us if we understand there's some gray area here, and a lot of times there's some consultation, some review of diagnostic testing, some other information that we need to collaborate on to determine how to best serve individuals and if we're able to serve those individuals. So please don't hesitate to reach out to us if there's questions. If eligibility is in question, we're absolutely open to reviewing it and collaborating with you and your teams and individuals that we're serving. Alrighty, individuals in this service category, of course, we already talked about, would be 18 years of age or older. We're going to skip to the next slide. We're going to look at the official definition of this population. So adults in this population would have functional limitations in 3 or more major life activity areas. Oftentimes we refer to those as adaptive functioning. that are not the result of one of the issues listed here. So the circumstances that they're experiencing would not be due to a medical issue, right? So it would not be the result of anything that's biological. Substance abuse, not the result of a medication-related issue, dementia, or neurocognitive conditions. That's important here. So an individual qualifying for REACH services under this part of the service population would meet all of the criteria we've looked at thus far. In addition, they would also have some type of co-occurring behavioral health disorder and or significant behavioral challenges that are contributing to the current crisis presentation. In addition, there's always some type of, not always, but there's often some type of risk involved for psychiatric hospitalization. Autumn talked about that a little bit earlier. In addition, risk of losing their residential placement. Perhaps they are at risk for hospitalization and losing their placement. Lots of risk involved when we're talking about this area. We can move on to the next slide. REACH services available to the expanded adult population include mobile crisis response, which Leave talked about a little bit earlier in the presentation. This service is accessed through our 24/7 crisis line. Once the individual is triaged through our crisis line, the call is made. One of our clinical coordinators triages the situation. If the individual is determined to actually be in crisis, our REACH staff will respond to that person in person, wherever that individual may be at the time. The intent is to collaborate with the individual and their system of care. So whether that be in the community, whether that be in the hospital setting, in their residential placement, wherever that individual is, the REACH staff would respond in person. Intent is to assess the current situation, find out as much as we can about what's going on, what is contributing to the presentation. It's really important to stress here the importance of early intervention when the hospital system's involved. So when someone's in the hospital, the earlier that they contact us and notify us, the earlier that we can respond and be involved, the better the outcome for the individual would be. It's not included in this slide, but let's talk a little bit about the secondary portion of services that are available to the expanded adult population, which would be our mobile support services. And those services are typically more intensive, and this may vary across the REACH regions, but typically the mobile support services would be an intensive type of support that would be a limited service, so time-limited intensive crisis stabilization, which would look like us sending a mobile supports staff out to the individual's home, residence, in the community, perhaps a day program, depending on eligibility and what type of the population and expanded population. Typically, those services are going to be very short-term in nature, anywhere from, I would say, 2 to 10 days, and that may vary depending on region, the REACH region where your individual lives. I'm not going to go into too many details there. There is some major differences between the expanded population and what we call the full REACH population. And if we have questions, we can address that, but there can be some gray area there. All right, we can move to the next slide. We're always really happy to share that REACH services are available to everyone who meets eligibility criteria, regardless of their ability to pay for the service. So an individual does not have to have qualifying insurance or a DD waiver or any other type of funding to be able to receive REACH services. The services are available to anyone, regardless of their ability to pay. When we talk about here, you'll see for individuals who utilize the DD waivers, REACH services are included in each waiver. Let's talk a little bit about the waivers. Virginia has 3 different types. So we have a building independence waiver, family and individual support waiver, and community living waiver. 3 different types. REACH services are included and funded through each type of waiver. And we can move forward. My computer's being a little wonky today, I apologize. All right, how to work with REACH. So, of course, our intent is to collaborate with the individual in the system so that we can create the most positive and meaningful outcomes for the people that we serve. If an individual accepts our service, no matter what part of the population for services that they fall under, it's really important that we're able to collaborate with the system and the team that's supporting the individual. And that could look like case managers, psychiatrists, community therapists, family members, guardians, sisters, brothers, anyone, spouses, anyone that is meaningful in that person's life that we're able to collaborate with. Being actively involved throughout the duration of REACH services is super important, especially when we talk about people that have good knowledge about the individual that we're serving and are able to openly share and advocate for that person and what their most meaningful life experience looks like. Participating in team meetings and trainings. Autumn talked about the crisis education and prevention plan. A huge part of that part of the services that we offer is not only creating and maintaining the plan, but also revising the plan as things change for that individual. It is a fluid document. We want to update it and keep it current so that the team is informed of what we've learned about the individual throughout the provision of services. Actively participating in discharge planning so that we don't just pull out and leave the system up in the air. We want to plan for discharge. We want to talk about where we're moving forward, what that person's life is going to look like when REACH services are finished. And like Erica talked about, when we have worked ourselves out of the job and are able to pull out, the main intent of REACH services as a whole is to increase the system's capacity to support the individual that we're serving. So when that process is finished. Alrighty, I think that's it for me, Denise.
Okay. So as you can see, REACH is a very comprehensive crisis systemic service. And you're probably thinking, how does that interact when we are working with folks who are homeless, in transition, of housing, et cetera? I think the main focus that I think for folks who are in the system and in the community is REACH comes to where you are. If just because somebody has, I think the perception, everybody with a developmental disability or under that umbrella has housing, has services, has resources. We know that's not to be the case. So you may interface at any time with an individual or a family or someone who has a child who is in the community without housing resource, but needs a crisis support or a crisis service. So really that's how, REACH can interface across the state. In this slide, and as Autumn talked about, this is the current access to the REACH regional crisis system lines. 988 is onboarding for the Crisis Now model and the one number, no wrong entry into crisis services. So as that comes on board, those resources will, change into that number. But currently, this is the number to call in the region. Now, I think your systems are broken slightly different, but regions for REACH are in what we call health planning regions. You can show the next slide, Kendall. I've broken those down. This is a lot of words, and you guys will have access to these. So, but you can see, because as Kendall informed me, that you all are broken down in a little bit different of geographic coverage regions. But this will kind of let you see if you're in a particular area. We broke it down as much as by CSB and then by county coverage areas, counties, cities, towns, so that you can find on here, okay, I have this family, they're in need of this service or this individual, and this would be the area and the location to call. I've included this. You can go to the next one, Kendall. As you can see, for each region and, the areas that are covered. This is for Region 2, Region 3. Then we have Region 4 and Region 5. All of this information, I think, is helpful when we serve, across the system, so that people know, where, because, some is urban, some is rural. Resources, vary differently across the state for different resources. So this can be helpful. And I've also included crisis service info, DBHS website, that shares information about what services are available, what crisis services in Virginia look like. You can see all the data from all of the programs if you're interested in that. The Department of Justice settlement reports I talked about, and also sort of the model of where crisis services are going, what the expectations are, and how that transformation is occurring. I included the crisis systems managers of the team that I'm currently on. And so any of us can be, you can reach out to us and we can direct you or answer your questions, or perhaps direct you and connect you with the services or the individual to answer your questions. And so now we would like to open it up for opportunity. If anybody has any questions, it could be, area specific, general, broad. Again, we have all of the REACH directors online here, and they can answer any questions if you have them.
Denise, one of the questions in the chat is, will we be able to receive flyers or other REACH material to share this great resource and opportunity? And I'll say, Denise has already shared these slides with me, so at the end of this meeting, I'll go ahead and send those out. This recording will be sent out, but do you all have any other flyers that you all are able to provide?
Each region has some developed flyers, if those would be helpful. We could, I don't know the best way to share those across. I don't know. We can. But yeah, each program has, sort of their REACH. It's basically what's captured here. But basically, are they asking, just to clarify, information that they can share in their communities?
I bet so, yes. And if it would be easiest, Denise, at the end of this meeting, I can also reach out to all the presenters, and we've got our crisis directory that we've provided. We can provide that again so everyone has the homeless services contacts. And then if you would be able to email me the material, and I could get it right back out to communities and providers.
That could work. Yeah, I did share that with them. That is great. So that's a good idea. And they can share the digital copy, and then you can make sure each region has that information. Mm-hmm.
I did have one question. Autumn, I think you spoke a lot to this, was with the Marcus alerts and oncoming 988. Would you be able to tell us a little bit more about that?
Sure. It's a loaded question. Someone could probably talk all day about all of what's coming, but not me, because I'm not even probably as versed as some of the folks at the department are at this point. But my understanding is that Marcus Alert is some legislation that is new in Virginia, with a heavy focus on helping to ensure that the right type of response is provided to crisis situations that arise in our community, instead of it always being a police response. We're making sure that if the person struggling appears to have mental health needs, that it's mental health providers that are the mobile crisis responders. And at times that will be still with a co-response with police to ensure safety, but with the mental health kind of component being primary and more of a support from law enforcement. So that is one piece that is a shift that is coming. In terms of REACH, that's not going to change as much for us, because this has already been our model, I would say. We want to be the response system for people with intellectual and developmental disabilities. Emergency services contacts us if they get a call on our individuals. Many of our law enforcement agencies already know to call REACH if they're responding on a call for an IDD individual. So we get tied in often to be co-responders. And so I don't know that is going to change terribly much for this population, but certainly it is, a shift for our mental health providers as well, in community and SUD. So that's one piece, is this legislation that's kind of an overarching change in our how we do business and how we provide crisis services. And it's going to be a rollout. It's phased, yes, the legislation is there, but how the services are coming online is very different region to region. The larger cities and catchment areas that have more of the resources are the ones creating co-response teams initially, with a plan to expand that through the entire state over the next few years. But in the meantime, there will still be changes that are occurring in terms of using the mobile crisis component in partnership with local law enforcement and the 988 number. So 988 is the statewide number that's coming online for mental health crisis. And so people can call that number and potentially access the National Suicide Hotline that way. Or they can call that 988 number, and trained mental health clinicians will help determine through warm line kind of screening whether this is someone who needs an in-person response. And if so, then they're going to contact the mobile crisis hubs that are located regionally. The REACH programs have a role in that level of care. We are the mobile crisis hub, at least in Region 4. I can say it's growing out of the number that we manage at REACH. And it's already a shared number with mental health, children's crisis, stabilization, and crisis response services. So ours is going to be growing, and those 988 dispatch workers will transfer the calls to us. And this is going to be an evolution. All of this is not expected to be, perfect and fully developed right on December 1st, which is kind of when we're looking at a lot of these changes kicking off, but will evolve over time as some of these infrastructure pieces continue to grow and come online. So for REACH, we have our separate numbers right now. I don't think that will ever change completely, but the 988 call centers will be a point of access to our mobile crisis services as well.
Autumn, thank you for that information. And we also had another question in the chat box. What is the process if someone is regularly accessing REACH services and interventions?
So if someone's known to the REACH system, they're going to have a coordinator who is assigned, perhaps, if they're open still to preventative services with a crisis plan that we're maintaining, that they may during business hours contact their coordinator and say, John has been struggling the last few weeks. Can you come out and do a home visit? Can we have a system planning meeting? Maybe let's look at his crisis plan, and it's a living document. So we're going to pull that out and look at it together. And if something needs to be adjusted, if there's a new service or support we can link to that may help strengthen the services in the community, we're going to do that. If it's if they can't reach their coordinator and there's something happening right now, they're going to call the crisis lines that we manage, and they're going to get an immediate, clinician who can help triage and determine if this is something we need to be doing now, or if it can be more of a scheduled follow-up by the coordinator the next day or the next business day. So that's one way that might look. If there's an acute crisis, then we're going to take the crisis side of things. It's going to take the lead, but they're going to be in communication with the prevention part of our system so that it's never, not really a wrong door. We would say if someone has an assigned coordinator that they're not calling them directly if it's an acute crisis, because not our staff might be in a meeting, they may be in an all-day training, or they just may be scheduled off. And certainly evenings and weekends, a lot of those positions are Monday through Friday. So you're going to want to use that crisis line if you're not sure, and they can help direct the call as well.
Thank you for that information. I'm not seeing any other questions in the chat, so I want to provide another minute or two for people to ask questions as I have them. Otherwise, thank you all so much. This has been really helpful.
Thank you for the opportunity. I do think crisis is under a robust overhaul in Virginia, and all of us are, running to try to keep up with it. But I think it will be, once the system, as Autumn talked about, the Marcus Davis Peters Act, which is what initiated Marcus Alerts, and in the changing way we access and provide services for folks in crisis across cross disability, from mobile crisis, walk-in centers, how and who we respond, and, all of those things. I think Virginia adopting the Crisis Now model is really their intention to meet the citizens of Virginia's crisis needs wherever they are, and implement resources and supports from whatever point they're starting from. And I think that's it's really incredible to kind of be part of, and to be part of, especially the REACH team, who do really great work with a really complex level of care need.
All right, and Denise and team, with that, I'm going to go ahead and stop the recording and again say thank you all so much for all of this incredible information and for taking the time to share this with our service providers and communities in Virginia. And I am going to go ahead and send out these slides. I'll also follow up with the REACH team to get some of their information, and I'll send that out as soon as possible.
Thank you, Kendall. Thank you, guys.